Assalamu alaikum. First of all, I would like to thank UMIDA board for inviting me to their conference, and also want to thank Professor Musbah Kamil for choosing this topic for me, because it is my passion, and I hope I will give a good presentation. The topic was diabetes and technology, but I added in developing countries, because we can see that the developed countries are using technology in diabetes in a wide scale. On the other hand, the developing countries, there are some misconceptions that hinders the use of technology in diabetes care. And I will concentrate on this misunderstanding. When we are talking about the use of technology, on one hand, we may talk about the innovation in insulin pump, in continuous glucose monitoring, in glucometer and point of care measurement of hemoglobin A1C, and the molecular biology regarding the etiology, the risk factors, and this kind of thing, and the innovation of new drugs. On the other hand, we can talk about other means of technology that help in management of diabetes and care of diabetics, like telehealth, telemedicine, mHealth, and eHealth. In our presentation, we will concentrate on this aspect. We will not talk about the other aspect. Now, regarding terminology, what is telehealth? Telehealth is delivery of health care over the internet, both clinical and non-clinical. For example, for awareness, for education, for continuous medical education, anything like that. But telemedicine is only for the remote clinical service, what we can call virtual clinics or something like that. Regarding mHealth, is using the mobile phone, mobile applications for the care of diabetics by any means to make care more efficient and fruitful. eHealth is a wider term that entails everything about technology in health, like any health service information systems that is done through the internet and the related technology. These are the terms so that we can be acquainted with it. The recognition of technology as an important pillar for diabetes care. Now it is growing this importance. The WHO, in its third report about global survey of e-health, said that this report was done by the Global Observatory of E-Health. They believe that global diffusion of e-health is the way for making universal health coverage. And in the International Diabetes Federation Congress 2022 in Lisbon, Professor Peter Schwarz was elected as a chairman-elect or president-elect. I quote, "I am dedicated to serve IDF and people with diabetes and to push for equitable diabetes care. I will use my medical, scientific, and social business know-how to support the need of people with diabetes to fight inequality in care," unquote. So the real discussion about diabetes and technology, what does it require? In fact, I want to say that both what Peter said, Professor Peter said, and WHO tells us that the e-health is the way for providing health care for the wide scale of people, whether in Africa or Asia or anything like that, including, of course, the developing countries. Real discussion of the recent technology, what is required. This is a conference after 1 week in Berlin, and it will be online as well. This is the program. It's a 4-day program with more than 40 hours lectures, excluding the industrial symposia. So there's 40 hours of lectures. And here's the Diabetes UK. There was a conference of type we and technology, and they summarized this conference in 5, 10, 15 videos with a total time of more than 4 hours. So, and this is a dedicated society for diabetes and technology with a quaternary journal, and it's another journal. So, it is impossible to talk about diabetes and technology in 15 minutes. So I will concentrate on 4 misconceptions about diabetes and technology, mainly in the developing countries. First of all, technology is useful, but has a limited role in diabetes care. If we are talking about awareness and education, technology is very important in the form of telehealth, like social media, Facebook, and this kind of thing. Diagnosis and treatment, the virtual clinic we have just talked about. If we talk about follow-up, well, all the time now talking about time and range. We can't know the time and range except with the continuous glucose monitoring. Again, management of diabetes. If we want to talk about diet, we will talk about the applications, mobile applications that help the patient to organize his diet and follow him up. Exercise as well with the mobile applications. Regarding complications, I will take one example, the retinopathy, for example, the digital retinal photography. We will concentrate on this example as an example. Remote retinal screening is performed at a point of care or a mobile unit. That means that we can get this device and put it in a mobile unit and move around the governorate to film all the patient in this area and send the images to a central office where somebody trained somebody, or even an analysis system that can read these images, so that we can cover the whole area with the experts in a central place. This is a paper about utilization of remote diabetic and retinal screening in the prepared health care system. The teleophthalmology is now considered by the World Health Organization, American Academy of Ophthalmology, to be an appropriate tool for population-wide diabetes retinopathy screening. This is the United States. As the demand for eye care continues to exceed availability, this is the United States. What about the developing countries? Teleophthalmology offers a promising alternative for delivering high quality, accessible care in a cost-conscious way. This is important, cost-conscious way. Second, technology is only for developed countries. Diabetes technology in developing countries, the problem in the developing countries is not the cost, not the lack of the infrastructure, not the lack of resources, but the unfamiliarity of healthcare professionals with new technologies in the main barrier to its use. In conclusion, the conclusion is that developing countries have to increase the use of technology in all aspects of healthcare, particularly in diabetes care. Of course, technology is very important in all aspects of medicine, but in diabetes care it has a greater role. Third, technology is not affordable by developing countries, and it is not cost-effective. This is a paper talking about cost-effectiveness of mHealth, mobile health intervention for prevention and control of type 2 diabetes in mellitus, a systemic review. This is a systemic review of 23 studies. And this is a conclusion. Cost of mHealth intervention very substantially, because if we're talking about insulin pump or continuous glucose monitoring, it is expensive, but there is other means that is much less expensive. However, where cost-effective results were reported, the intervention was cost-effective. Another study about the cost-effectiveness of mobile-based intervention for patients with type 2 diabetes. In conclusion, this study reveals that the mobile-based intervention could improve the control rate of hemoglobin A1C with a better cost-effectiveness. The fourth one, we don't have the needed infrastructure for such technologies. In fact, in Egypt, we have 94 million smartphones, not phones, smartphones. So be sure that in every household there is someone that has a smartphone. This is a data portal for Digital Egypt. There is 75 million internet users in Egypt. This is 72% of the population. So the infrastructure is there. In conclusion, diabetes technology for developing countries is, number one, fundamental for better universal diabetes care. Number two, important as well as for developed countries, for the developing as well as the developed countries. Affordable and cost-effective, possible as the need of infrastructure is already there. Now, in a minute or two, I'm sorry to say, I will tell you my own experience. It's a real experience to try to adapt these technologies, the available technologies, in a very remote area in Emad Hamed in Upper Egypt, 600 kilometers from Cairo. We tried to do things. Number one, implementation of technology enhanced diabetes care in a remote underprivileged area of Upper Egypt, Emad Hamed, establishing an online care and follow-up for patients from the same area and the wider geographical area. I will explain why wider. In the beginning, we started with a desktop application for the electronic medical records. We have the server in our center, and the whole team can access the data, whether to input or review it, so that we established these things around 2013, from 10 years now. When Corona came and started, we have to shift our practice, so we resorted to host our data on the cloud so that the whole team can access the data from their home and we can access our patient in their homes. Today we started to the beta version of the mobile application. We have a mobile application for the patient, a mobile application for the team, for members of the team. It will be a real cloud computing so that we can access our patient everywhere, on any platform, in an easy way. We use Facebook and YouTube for patient education, the words of this kind of thing, with Zoom and Google Meet for our conferences, for our continuous medical education, and for controlling our business. And this is an application called Docs.me. It's a very nice application, very easy one, so that you can communicate with your patient very audiovisually in a very simple way. It doesn't need any technical abilities from the patient side. And last but not least, WhatsApp, which is a very valuable way to keep in touch with your patient all over time. We started in Emad Hamed, but for some reason or other, we started to move. So one of our diabetes educators now in Alexandria, another one in 6th of October. What is that? هاتي عيب التكنولوجيا بقى. حد يلعب اكس بوكس. ايوه. Anyway, because of certain causes, the team of the members of our team moved. Some in Alexandria, some in 6th of October, some in Sohag. And I moved to Cairo. After 40 years, I practiced medicine and mainly diabetes care for 40 years in Emad Hamed, but I moved now to Cairo. So that the use of technology helps us to continue our practice in spite of these geographical hinders. Okay. As I said, now our patient, the main bulk of our patient, I started in Emad Hamed, as I said, I practiced for 40 years. Then some patients moved to Alexandria. We are following them in Alexandria, in Lower Egypt. in Cairo, in Bani Suef, in Hurghada, in Sohag, in Aswan, and sometimes our patients move to Saudi Arabia, Kuwait, Qatar, United Arab Emirates, and we can still follow them up all the time because of this technology. The recommendations. Number one, we should encourage healthcare professionals to explore the available suitable technologies. It is important to get suitable. Everywhere there is something suitable and something is not. Suitable technologies, tools that help them to improve their practice. As we said before, the main hinder in the way of using technology is the lack of vision in the side of the healthcare professionals. The IDF, its regional offices, and the National Association should A, invest and facilitate the spread of awareness, knowledge, and know-how of all possible technological tools through their website, and to ensure that all these resources are free for all. Number B, take the responsibility of endorsing the mobile applications and other resources that fulfill the recommended standards. This is very important. All the healthcare professionals and the patients are overwhelmed with hundreds and hundreds of applications. Some of them are useful, some of them are not, some of them are harmful. So we should have an authority to say that is good, that is bad, so the patients and the healthcare professionals will not go into this dilemma. Now, I hope that sometime in the near future, there will be a conference dedicated for diabetes and technology, because I think we in developing countries in bad need for the technology to help us to improve our practice in medicine and in diabetes especially. Thank you.